Welcome. We're jumping straight into a really key topic today, managing heart failure with reduced ejection fraction. Specifically, the ongoing chat about the best RAS inhibitor.
The American guidelines often point towards Sacubitril valsartan, or SV,
Yeah.
but it's not without controversy, is it?
Not at all. There's a lot of discussion, a lot of questions about where it really stands compared to the older, the established ARBs and ACE inhibitors.
Exactly. And that's what we're diving into today, a meta-analysis that tries to really unpack that comparison.
Right, pitting SV against both equivalent and subequivalent doses of ARBs or ACEIs. Try and get some clarity.
Precisely. We want to look at what this specific research tells us about how these options actually stack up against each other.
And our source for this is a 2024 meta-analysis just published in the European Journal of Clinical Pharmacology. The authors are Joseph Rendon and Chadwick Millen. For anyone listening who treats HFrEF patients.
Absolutely. These are cornerstone medications. Understanding the comparative effectiveness and, importantly, considering the cost. It's crucial for patient care.
Okay, so let's get into the study itself. This meta-analysis by Rendon and Millen.
They pulled together data from 12 randomized controlled trials, over 17,000 patients with HFrEF.
So,
One group compared SV to what they define as equivalent doses of an ARB or ACEI. The other group compared SV to subequivalent doses, basically, lower doses of those older drugs.
that distinction seems critical. How did they actually define equivalent dose? That can be tricky.
It can be. For this analysis, they set specific benchmarks. So SV 97710 milligrams twice a day was considered equivalent to valsartan 160 milligrams twice daily,
Okay.
or equivalent to enalapril 20 milligrams twice daily, or ramipril 5 milligrams twice daily. Those are the key equivalencies they used.
Got it. So based on that framework, what was the core question they were trying to answer?
The main goal was to see how SV stacked up against these equivalent and subequivalent ARB-ACEI doses when looking at major outcomes.
Like mortality.
Exactly. Total mortality, cardiovascular mortality, and also worsening heart failure.
And, speaking of staying on top of the latest cardiology research, this seems like a good moment to mention something for our listeners.
Well,
Yeah, especially those who are cardiologists. There's a new podcast called Evidence-Based Cardiology Talks. You can find and subscribe to Evidence-Based Cardiology Talks on Spotify and also on YouTube. And it's produced under the supervision of Dr. Caroli. He's a cardiologist. His website is drcaroli.com if you want more info. So back to this meta-analysis.
the equivalent dose group and the subequivalent dose group. They wanted to see if SV showed a consistent benefit across those crucial outcomes in both scenarios.
Okay, let's get to the results then. What do they find when SV was compared head-to-head with equivalent doses of ARBs or ACEIs?
This is maybe the most striking part. In those equivalent dose comparisons, the meta-analysis found, well, no statistically significant difference.
Really? No difference in total mortality?
Nope. Or cardiovascular mortality, or even worsening heart failure. At equivalent doses, SV didn't show a clear statistical advantage over the established agents.
That's quite significant given the usual narrative.
It really is. It challenges some common assumptions.
Okay, so what about the other scenario? When SV was compared against subequivalent doses, lower doses of enalapril, for instance.
Well, that's where the picture changes. In those comparisons, primarily against lower dose enalapril, SV did show a significant benefit.
A benefit across the board.
Yes, statistically significant reductions in total mortality, cardiovascular mortality, and worsening heart failure, all favoring SV in that specific comparison.
Interesting. So the dose of the comparator really seems to be the key factor here.
It looks that way. The dose matters.
Can you give us the actual number, the risk ratios they found for that subequivalent comparison?
Sure. For total mortality comparing SV to subequivalent enalapril, the risk ratio was 0.85. The confidence interval was tight, 0.78 to 0.93, and p-value less than 0.001. So, clearly significant.
Okay, 15% relative risk reduction there. What about CV mortality?
Even a bit stronger. Risk ratio 0.81, confidence interval 0.73 to 0.90, p-value also highly significant, less than or equal to 0.001.
And worsening heart failure.
Risk ratio 0.77 there, confidence interval 0.64 to 0.92, p-value 0.005. So again, a clear statistical advantage for SV in that context.
Right, so a clear win for SV against lower doses, but parity against equivalent doses. How did Rendon and Millen explain this difference?
Their interpretation leans heavily on the dose-response relationship we know exists for ARBs and ACEIs in HFrEF.
Meaning you get more bang for your buck with higher doses of the older drugs.
Essentially, yes. They argue that if you're comparing SV to an ARB or ACEI that's not dosed optimally, maybe at a lower subequivalent dose, then SV might look better, simply because the comparator isn't delivering its full potential benefit.
That makes intuitive sense. Did they cite other evidence for that dose-response effect?
They did. They pointed to classic trials like the ATLA study with lisinopril.
Right, higher dose lisinopril did better.
Exactly. And also the HEAL trial with valsartan, which showed a similar thing, better outcomes with higher doses in heart failure. It reinforces the idea that maximizing the dose of the traditional RAS inhibitors is important.
Now, you mentioned earlier that the overall results were heavily influenced by a couple of specific large trials included in the meta-analysis.
Yes, the authors highlighted that. The results were significantly driven by Paradigen HF.
Which used the subequivalent enalapril dose, right?
Correct. That one showed SV superiority.
Yeah.
And then there was the Paradise MI trial.
Which compared SV to ramipril after myocardial infarction.
Right, and used what the meta-analysis authors considered an equivalent dose of ramipril 5 mg twice daily. And Paradise MI, notably, did not show a significant benefit for SV over ramipril for its primary endpoint.
So those two big trials pulling in different directions depending on the comparator dose.
Precisely. And that feeds directly into the meta-analysis findings.
But isn't there also some debate about whether that 5 milligram ramipril dose is truly equivalent to the 10 milligram enalapril dose used in Paradigm HF's comparator arm, or rather equivalent to the SV dose?
Yes, that's a really important nuance they touch upon. The whole ramipril versus enalapril dose equivalency is murky.
How so?
Well, the paper mentions different proposed ratios, like 1.2 or even 1.4 between ramipril and enalapril. And there's also some evidence suggesting ramipril might actually be more potent in inhibiting ACE activity at these kinds of doses compared to enalapril.
So the 5 milligram of ramipril in Paradise MI might have packed more of a punch than a strictly equivalent enalapril dose would have.
It's possible. That could definitely complicate the interpretation of why Paradise MI didn't show a benefit for SV, and it adds another layer to understanding this meta-analysis. It's not always straightforward.
It rarely is in medicine, is it? Which brings us, inevitably, to cost. This is a huge factor in the real world.
Absolutely unavoidable. Sacubitril valsartan is significantly more expensive than the generic ARBs and ACEIs.
How much more expensive are we talking? Did the paper give numbers?
They did provide some ballpark figures. SV around $650 a month. Compare that to lisinopril, which can be like $10 a month.
Wow.
And valsartan maybe $30 to $60 a month. It's a massive difference.
And the authors pointed out the societal cost implications of that, right? Especially if SV isn't clearly better than equivalent doses of the generics.
Exactly. The potential healthcare system cost is substantial if SV becomes the default first-line agent for everyone, based largely on trials comparing it to suboptimal doses of older drugs.
And it's not just the system cost. It hits patients directly in the pocketbook.
For sure. High copays for SV can lead to non-adherence. They cited research showing just that patients are less likely to take their medication consistently if the cost is too high.
Which obviously negates any potential benefit.
Right. And they also briefly mentioned that we're now adding SGLT2 inhibitors into the mix for many HFrEF patients based on guidelines.
Adding even more cost to the regimen.
Potentially, yes. So the overall financial burden of optimal HFrEF therapy is climbing.
Okay, so pulling all this together.
According to this analysis, SV doesn't appear superior to equivalent doses of ARBs or ACEIs for these major HFrEF outcomes.
But it is superior to subequivalent doses of enalapril.
Correct. So the crucial message is that the dose of the comparator drug really matters when we interpret these studies and make decisions. Precisely. It's about optimizing the RAS inhibitor, potentially pushing the dose of the generic ACEI or ARB first, and having a very clear reason, likely based on comparison to suboptimal dosing, if choosing the much more expensive option up front.
It certainly gives us a lot to think about.
It does.
Which leads to a final thought for you, the listener. Given these findings, particularly the lack of superiority against equivalent doses and the very real escalating costs, how do we best balance things? How do we balance the potential benefits of newer therapies like SV with the proven efficacy and, frankly, the affordability of optimized doses of older agents like enalapril or valsartan when we're personalizing treatment for our HFrEF patients?
It's a critical question.
Definitely food for thought. Thanks for joining us.